Sonia MacLeod, who's a researcher in civil justice systems at the Centre for Socio-Legal Studies at Oxford University, and Dr. Jenny Vaughan, who's a consultant neurologist and the Learn Not Blame policy lead for the Doctors Association UK. Thank you both very much for joining us this morning. I'd like to start, if I may, with Dr. Vaughan. You've looked at these issues extensively, and you've heard this morning what happens in Sweden. You've also heard some of the evidence that we heard from two dads who had really horrific experiences when things went wrong in our system. What do you think the biggest barriers are to a learning culture in the NHS that could bring our neonatal death and disability levels down to Swedish levels?
Yes. Can everyone hear me all right?
Yes, we can.
And again, I did hear, I was trying to call a couple of patients from my clinic this morning, but I did catch the end of James and I heard all of Darren's. And I want to express my heartfelt apologies for what happened there. I think the biggest barrier is really our fact that that people feel that if they really own up to an error, that they're going to be blamed for it. It is our blame culture, which is very toxic. And it's very sad, Jeremy, because I'm sure you and the panel remember what happened in 2013. We had the Berwick report, and there were all sorts of very powerful recommendations that came out of that. And then that was obviously in the light of mid-staffs. And then since then, you have to look back and say, have we really learned? So the barriers are all about communication and people feeling that they may be blamed. And it creates a very toxic culture. On the front line, which is the main part that the Doctors Association represents, we are still working in a resource poor organisation. We are, and there is still opportunities for training that aren't always realised. People can still feel very isolated and vulnerable when they're making decisions, and we're all human. And with the best will and intention, we don't always make the right decisions. And when something happens, the problem is staff feel that they will be blamed. What we need to do is revert to really bring in the work that Aidan Fowler has been responsible for, NHS improvement, bring in a just culture where we ensure that anyone showing intentional to harm, so if we're talking about mortal wounding or intentional harm, willful, reckless conduct, those are taken out, because nobody is trying to defend anyone committing those sorts of errors. This is not about giving doctors or nurses or midwives a free ride. This is about honest error and how we deal with it. If we don't promote the open culture that Dr. Gustafsson was talking about, that actually James and Darren alluded to, they didn't get an apology. If we don't promote that and get the first investigation right, then everything else doesn't seem to, falls out from that. I just wanted to also mention the work of Leslie Hamilton, because although I come from, the cases I've been involved in, because I'm not an expert in maternity care, I've been involved in the rare cases of doctors who've been accused and actually convicted of criminal gross negligence. And in those cases, it was very clear that because they didn't get the first investigation right, because the first investigation was all about fixing the blame, everything else that happened after that didn't go right. You then expose yourself to the courts and the coroners. Not that those are necessarily wrong, because some cases have to go there, as we've heard this morning. But the vast majority of cases, and in particular, I defended David Sellu from a medical point of view. That case should never really have gone near a criminal court. And there's a massive outcry from the profession about what happened to Hadiza Baragaba, because there were frankly so many systemic errors. Now, what Leslie Hamilton was tasked with doing, and Norman Williams, who you tasked Jeremy, I'm sure you remember this, with looking at these cases, you tasked them to try and understand what it was that might actually, reduce these cases ending up in a criminal court. And what came out of that was a whole raft of investigations, but the most important was getting the first investigation right and ensuring that, you had open communication with relatives, that you fixed someone in the hospital to be with the relatives who were there throughout the process so that they could tackle the issues that James and Darren raised about poor communication, an apology, what actually went wrong for the patient. And then secondarily, for the member of staff, that you're looking at that investigation from a systems point of view, seniority, systems, and not saying, how do we fix someone who's going to be the fall guy or girl for this?
Thank you. I do remember those issues very well. And indeed, you helped Norman Williams, I think, in coming to the conclusions that he came to. You talked about training and you talked about resources, and they obviously matter. But can I just ask you very specifically, when it comes to changes in the law, what would help get rid of this blame culture and allow a learning culture to take stronger root?
I hesitate to say this, but I actually don't think the law is necessarily... I think it's all about changing our system. I think if we wait
what
for
system
law
changes then? Tell me what system
Yes,
changes.
the system changes that need to happen are... I think we have to accept, whether we can fix it or not, that actually tort law, the finding of fault, is not the answer for the vast majority of these cases. And the changes that need to happen are what's outlined in Aidan Fowler's Just Culture, and making sure that comes across to the NHS. So taking out the intentional cases, taking all of those and making sure that they're accountable, and bringing in candour, apology. This is going to be an open culture. And then you get more back to what we've heard about happening in Sweden, where people feel much more confident that if they speak out and admit their error, they're not going to be blamed for it. One of the worst things one of the most important things to tackle is defensive medicine and stopping staff hiding their errors. The only way you do that is if you bring in a just culture and you say to staff, we are going to create a system where you can talk about the errors openly. You've brought in the concept of safe space. I know that hasn't gone through yet, but I think that's a really, really important part of this, so that staff can open up about what happened, why it happened, and how they can learn from it. Because the problem with all of this is, unless you break down these barriers, unless you change the system and you allow people to do this, you actually won't promote learning. You will get a worsening culture of defensiveness, and you will never, ever actually tackle the problem. So that it has to be part of the solution. And I don't think the law can provide that. When it comes to the criminal law, if you can pass recommendations and you can get agencies like NHS Resolution, NHS Improvement to say, this is how we want it to be done, and bring that in, then that could have a big effect on what happens going forward. But certainly, just keeping going with what we have at the moment, it will never ever, it will never ever improve. It has to be that we embrace just culture, and we embrace not no blame, but openness and accountability that looks forward. And it was very interesting. I was reading a lot of what Aidan's put forward, and also Sidney Decker, and we have to look in all of these things. Who is hurt? How are we going to make it better for them? And whose obligation is it actually to do that? If we look at those three elements, that will go a long way to stopping how do we fix the blame very early on in these investigations. If all parties concerned sit down and say, this has happened, who is hurt, what do they need, and whose obligation is to provide that, I think those three very, very simple principles operating within just culture could make a very dramatic difference. But we have to be committed to it, and we have to say, this is what all our organisations have to do.
Can I just ask you one last question, and then I've got some colleagues who want to come in. This is about tort law. So one of the differences that we heard from Dr. Gustafsson in Sweden was that in Sweden, you don't need to prove gross negligence by a clinician in order to get compensation. You only need to prove that care wasn't delivered according to best practice. So the bar is much lower. We also heard from Helen Vernon that she's settling 2 multi-million-pound cases every week for a severely disabled child, including one this year of £37 million. For a parent, when a child is born disabled, they're obviously very worried about family finances and they want to get as much support as they can. the only way they can get that support is if they can get someone to agree there was gross negligence. Do you not think that there is some element where the law incentivizes confrontation rather than the just culture that you're talking about?
I mean, totally. I mean, just looking at this, in the law, you don't have to prove that the staff was guilty of gross negligence, because obviously that's beyond the pale. That's the most severe. It's more that it's the civil standard of clinical negligence, which is different from the criminal standard. I do think that a basic problem with the system is that in order to get compensations, parents have to sue, particularly in maternity, and that's the way we've set it up. And I do think that what we've heard this morning from Sweden is very, very powerful, because it seems to me that several years ago they were operating like us, and they've actually managed to change their system. And I think that we should listen very hard to what Dr. Gustafsson has said in that respect, and we can learn from that. That's really, really powerful. From the point of view of learn, not blame, we must prioritise and bring in, I think your work with safe spaces, I think is really, really important, and bring in and emphasise freedom to speak up and what goes wrong. Because in all of this, the most important thing from the parents' point of view is what I've said previously, and that is, if you have been harmed, that you have appropriate support, you have an honest explanation, and you have compensation if you are due it. If you are a member of staff on the front line, the most important thing from your point of view is that you feel able to talk about it, that you feel able to learn from it, and that you're not going to lose, your livelihood, your reputation, and everything that goes with it. So if you can actually ensure that you're tackling both of those two, I think we've actually got a consistent way ahead here. And I think we have got solutions to the problem if we look at both of those two areas. And then from an organisational point of view, if you're an employer, there's all sorts of duties that you must comply with. But the tendency that we see on the front line is for employers to kind of just say, well, who's to blame here? And we need to change all of that. We need to have, in order to bring an open culture, you need an employer to say, the default is it's actually the employer that may well have caused this to happen once you've taken all those intentional errors out. We're talking about honest errors.
Thank you, Jenny. I'll bring you back in a sec. Yeah. Because we've got Sonia McLeod, who's also I need to bring in. But just before I bring in Sonia, I've got some colleagues who want to ask you some questions, Jenny. So I'm going to start with Taiwo.
Thank you, Chair, and thank you, Dr. Vaughan. My question was regarding, you mentioned earlier about Dr. Selliot and the importance of healthcare professionals being able to talk about the situation and what we can learn from it. So I would like to know, at what point do you think oversight bodies should have drawn the line between a standard mistake in diagnosis and which would rise to the level of gross negligence? And I would like to understand what factors should have also been taken into account in that situation and what we could have learned from it.
Well, I can tell you that, just going back to my point, the investigation was the one that went wrong there. The first investigation that happened, which was with the hospital investigating what happened to Mr. Hughes in the Selliot case, was all about fixing the blame. And one of the most important recommendations that came out of Leslie Hamilton's review, which followed on from Norman Williams' review, which Jeremy was involved in obviously asking for, was that if you get a first investigation and a member of your staff is actually under investigation for a criminal offence, the CQC should come in and look at that organisation, because either that organisation is dysfunctional or that department is dysfunctional. Now, that hasn't happened. And in answer to your question, we've moved forward and tried to learn some of the lessons of the Selliot case. And one of the most important lessons is what you allude to, and that is that you don't just look at one individual, you also look at the organisation. And if that first investigation isn't right, and that applies across maternity care as well, from what we've heard this morning, we've heard two very powerful patient advocates talk about the failures of the first investigation of what happened after the death of their children. If that's got right, and if you actually look at the investigation as well as the staff, then you should avoid a lot of the fallout that's going on. And I don't think there should be early resort to criminal investigation either. My overwhelming impression of what happened in the Selou and the Bauer case was that early resort to criminal investigation helped no one. And the police did, particularly in the Selou case, assume that the organisation was free of blame and that everything that virtually that organisation said was what actually what happened, when in fact we found the reverse was true, and that actually there was some covering up going on there on behalf of that organisation. And so the only way to stop that happening is to investigate both of them, and that did not happen in an equal fashion.
Thank you.
Thank you. Thank you, Chair.
Luke Evans.
Dr. Vaughan, thank you very much. And to pick up on some of those points, I know from my time in practice, one of the biggest things in terms of defensive medicine is the approach that clinicians take. They're always thinking in the back of their head, am I going to get struck off if I miss something here? To that line, that leads immediately onto the GMC and the way in which the GMC feature a role. You've hinted a little bit about the CQC. I just wonder how we try and unwind that approach and what roles the regulator in terms of the GMC has in it, because at the same time they're the ones that doctors pay into to be able to practice, and yet they're the ones who hold the gate as to whether you can indeed carry on practicing and the investigations to go there. Is that perception from the medics that are practicing, is that just wrong? Is that the GMC, or is there something else going on here that could be done to affect that?
Well, I mean, I think the GMC, of course, fulfills a very important role. You know, patients have to know that the doctor that they go and see is able to fulfil certain standards. They have to have that confidence. So there are certain things, we can't get rid of the GMC. They fulfill a very important role. Having said that, I'm sure you saw the fallout that happened as a result of the Bauer case. And I think that's why Jeremy was right to take it so seriously. Which he did. And there was a lot of soul searching that happened at the GMC after that. And they have actually learned quite a lot through their processes since the Bauer affair. My concern is, and there's been a lot of work by Roger Klein and Dr. Doyen Atalogan, is that there is a race issue here, and that I'm not saying the GMC is racist, but there is a fear amongst the medical profession, and many of our staffs are from Black and ethnic minority backgrounds, that when they look around and they see who actually gets convicted, who actually gets referred in excess numbers to the GMC, there is an excess number of Black and ethnic minority doctors. And I was very concerned if I look at one thin end of the wedge, and I just looked at gross negligence manslaughter, and these are small numbers, so you have to be very careful about interpreting it. You know, there seemed to be equal number of charging decisions by the CPS of Black and ethnic minority and white versus white doctors. But actually, when it comes down to it, only in the last 10 years, it's only Black and ethnic minority staff that have actually been convicted. I mean, that includes Portuguese staff, you know, anyone from a Black or ethnic minority. It's them that are actually convicted. So I think the GMC has a hard task because it knows that actually, if you're a white doctor, you are more likely, you're less likely to be referred to the GMC. And I think there's a danger that Black and ethnic minority staff think that the GMC is more likely to be used as a weapon against them. And there is a tendency in hospitals for people just to say, you know, I'll refer you to the GMC and use them as a weapon. And I really hope that by working with the GMC, you know, all of our politicians and doctors, our doctors' organisations, by working with the GMC, we can actually diffuse some of this fear, some of this weaponisation, and for the GMC to be more mindful about those investigations that don't need to go anywhere near them.
That's really important, and you touched on two parts. The first part was, in the case you referred to, was about the reflective learning and openness, and there was a big fallout by the medical profession about what they would even write in their reflective learning and what they would be prepared to have in their appraisals and discuss. And so you've got two levers pulling against each other. I wonder what your comments are on the reflective learning to try and improve as a clinician, but also on that side, in your experience with regards to the BME and getting complaints, how much of it is down to communication as opposed to actual ability with in terms of practice or outdated practice methods if it's coming from abroad? Is there a discrepancy between the two when you're comparing British trainees and British trained graduates, both white, both BME, and then doctors from abroad. Are you able to address both those sort of angles?
I think, can I just deal with the first one?
Yeah.
With the first one, because the reflective practice was huge for the profession, really huge. That's the way we learn. It's when you sit down and you talk to someone and say, I got this bit wrong. There was a grave concern that actually criminal courts could access reflective practice, and therefore doctors and nurses would be denied learning from these incidents. Reflective practice notes can still be accessed by a criminal court, but the GMC then agreed that they would not call for them when they were investigating doctors, and you were due for a hearing, which I think was very helpful of them actually. Although reflective practice, I'm sure you know yourself, can be used in your favour as well, but you have the choice. I think to a large extent, the details about reflective practice have been addressed by the report by the Academy of the Medical Royal Colleges, because they specifically looked into this and they produced a lot of guidance for the profession about anonymising. So a lot of the fear that came out surrounding Bauer-Garber and reflective practice has now been addressed by the Academy of the Medical Royal Colleges, and I was very pleased with that report. But obviously we have more work to do, and there is still a fear out there. So you are very right to draw that to everybody's attention. Now, going on to black and ethnic minority doctors, I think it's going to take me quite a long time to answer all of your points there. And what I'd like to do is I'd like to send you a very full written report on that issue, which answers all of your concerns, because there is no doubt that there are great concerns about how black and ethnic minority doctors are dealt with. I don't think it's not as simple as saying it's because they don't learn what they should do abroad, because Hadiza Bauer-Garber was actually fully trained in this country, and David Sellew did his medical training in this country. So it's not as simple as saying they come. I think there are some complex cultural issues. I think there is racism. I think there is. I've obviously said the GMC I don't think is inherently racist, but I think there is. We all know that there is racism in our society. And I think there's a very, very complex way of trying to understand that. So I would like to actually send the committee a full written submission on that, so that it actually answers about 5 or 6 of your points, because I think it's absolutely key we try and understand that. I've done quite a lot of work with Roger Klein. I communicate with him regularly, and I would like him to...
We welcome that. We are in a separate session looking at BME and the workforce burnout, so I think that would work across both if Chair is happy to accept a submission on both sides. And on that, thank you very much for answering those questions. Back to you, Chair.
Thank you very much indeed. A final one from Dean on this, and then we'll move on to Sonia MacLeod, who's been very patient.
Thank you, Chair, and thank you, Dr. Vaughan. My question is just about this culture of learning that we've touched upon. We live in a digital age, and it sounds to me, from everything we've heard so far, is that this is very much about a person-to-person reporting up concerns and issues. And as I understand it, the NHS has well over 1 million members of staff. Has there been any investigation or look at the use of technology to enable people to who are staff anonymously report concerns or share learnings or identify areas for an improvement? And if that has been looked at, I'd be interested to find out. If not, is there a thought on why? And my attached question to that is that is there a concern, do you think, that actually if every member of staff shared a learning or a concern about issues, that actually it could open a Pandora's box of problems that actually it's easier to be ignorant of rather than actually address?
I think the first important thing to say there is that actually there should be a presumption of good intention until we go anywhere else. Most staff, when they come in the NHS, they're coming in to do a good day's work. And when you look at error, and I'm not an expert in error, but I know people who have, when they've looked at those, they found that, there are hundreds and thousands of errors that could happen each day, and they only don't happen because of the good intentions of the staff. And the other worry is that we shouldn't be driven just by outcome. We become suddenly very focused on if someone dies or some awful thing happens. But actually our approach, whether something doesn't happen or it does happen, should always be consistent in each case. And bringing that consistency in is really fundamentally important, because if you don't do that, you end up with people just being horribly reactive to when bad things happen. And that's why you get the culture of fear. I think technology has a great deal to do with this. And we already have the DAUK system in our hospitals where people can register things. But I can tell you, and you won't be, sadly, you won't be surprised about this at all if I told you that DAUK is also used as a weapon in healthcare. And I have a feeling that if I wandered into a Swedish hospital, that wouldn't be the case. So they are obviously doing something really right there. And we need to just have a look, very careful look, and look at how we do it, because we've got the stuff in place. We've got DAUK, we've got the right, we've got committed staff who in general have good intentions. And it's about using all of that. And I absolutely believe that I know that if you look at, particularly in maternity, if you look at a lot of the times when things have got wrong, simple things like the doctor there didn't have the full notes of that patient's pregnancy, wasn't aware that the baby wasn't growing, quite well at this stage because they didn't have the notes and they were dealing with all sorts of other things at the same time. Very simple things like streamlining patients' notes, having access to full electronic notes, I think would help that. So there are very simple errors that actually software and technology could really help us with. But it's not all the answer. It's not the whole answer. The whole answer, the answer has to include good intentions, not just being focused on bad outcomes, and trusting staff and really studying hard, other nations who have obviously got this, they've got this just culture more in place than we have, and learning from them.
Thank you.
Thank you. And I think Rosie Cooper has a last question for you, Jenny.
Thank you. I'd like to address whether the NHS actually does learn from serious incidents. And I ask that because of my involvement in Liverpool Community Trust, where Professor Kirkup is currently doing a second investigation. And the culture in the new organisation has changed to from rather who did it to what happened, which is really good. But the reality is everybody missed it, all the regulators, everybody. And when it came to it, what happened was there were action plans for everyone involved, including the Centre, NHS England and everywhere. But everybody held all the constituent parts to account. And yet the NHS England didn't really look at itself. The regulators haven't really looked at themselves. So I want to go on to agree that DAUK is used as a weapon, but...
Oh, Rosie, I think we've lost you for some reason. Rosie, can you hear me? I'm very sorry. I think we've got a technical glitch there. It's what? Okay. Rosie, we've lost you there. I'm really sorry. Can
you hear me now?
We can hear you now. Right. Could you be very brief, because we've just got to wrap up this bit of the session.
Absolutely. Where did I get to?
I don't know. You just do it all from scratch, but very briefly, please, Rosie.
Okay, I'll do it very quickly. Liverpool Community Trust, the culture changed from who did it, from what happened, who did it to what happened. Really important change. Everyone missed it. Regulators, the centre, and even everyone wants to hold everyone else to account, and yet they don't hold themselves to account. He also went on to say about DAUK, yes, I do agree it's been used as a weapon, but actually junior staff use it to protect themselves against an exec or NHS England, whoever.
What's the question, Rosie? So sorry.
Right, so I really want to know whether the NHS actually does learn from serious incidents. That was the first comment I made.
Jenny.
Well, Rosie, I think you're absolutely right. Are you all right to call you? Am I all right to call you Rosie?
Oh yeah, please.
You're absolutely right, because I've listened to you before on the committee. You always highlight very, very important things because you're intimately involved in them. And you're absolutely right. There is a track record of the NHS. We have scandal after scandal, but we also have, and let's make sure that we don't lose focus of this, we also have a record of the number of the thousands and thousands of patients that we treat safely every day, and a very dedicated staff, and a system, frankly, that for all its faults, I've worked in it for over nearly 25 years now, and it saved my life as well. That it's, I'm still immensely proud of what we've got in the NHS. But I'm actually I want us to look forward, and one of the reasons I was really very pleased to come along and give evidence today was I thought I really recognised that I think we've reached a turning point. I think we've heard some really powerful testimony. It's not that we haven't heard that before this morning, we have, but I think we can actually really move on, and we're going to come out of COVID, we're going to get stronger, and we are going to change our culture because we have to. We have no choice about that. So I have no argument in agreeing with you that the NHS has had problems learning from its errors, of which there have been many. And I have no problem with expecting that we will continue to make errors, because to err is human. But I really believe that if we adopt some of the principles that we've heard about this morning, which is our duty and our responsibility, that we do have a better future to look forward to when it comes to us as patients, of which I am one. I'm very confident to keep the NHS keep treating me, and also for our staff. And I as one of those, I'm very, very committed to staying within the service and us all serving the patients that we need to. So I think you're right, but I think in the future, if we actually adopt these principles, we will change, because we've seen Sweden, we've seen Dr. Gustafsson tell us that that's possible. And I firmly believe that. And I've also been to New Zealand, where I've seen that in process as well. So I do believe it can happen for the NHS.
Thank you very much indeed. And last but not least, and thank you for being so patient, Dr. Sonia McLeod, who's a researcher